Bye.
Hello, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken. This is your one-stop shop for all things eyeball related. I am fresh off a first in my life. I do a lot of speaking, do a lot of conferences, and I got to go finally for the first time. I was invited to a gynecology conference. This is, I dare I say, that this was the first time an ophthalmologist has ever been to a gynecology conference. This is specifically gynecologic oncology. Shout out to the Society of Gynecologic Oncology for inviting me. It was a bit of a surprise, honestly, because as I'm reminded over and over again, I don't have a lot of gynecology content. It's although so many specialties are outside my wheelhouse as an ophthalmologist, this one could not be further. They're very much almost no overlap whatsoever. The most overlap is maybe like preeclampsia, because you can see like some eye changes, gestational diabetes, you get diabetic retinopathy. So there's stuff there, but in general, we don't have to interact with each other. And as a man, I'm not in that world. I didn't grow up in that world. And it's not my thing. And I just don't know a lot about it. So the content hasn't been there for that particular specialty. Same thing with plastic surgery. I don't do a lot with plastic surgeons or dermatologists. To be honest, there's a little bit more dermatology there. But anyway, the point is there's a few blind spots, a few things that I don't have a lot of content on. So when the gynecologic oncologist came calling, I was like, oh yeah, let's do this. And I had some special things for them. I told them that even though we don't seem to have a lot in common, we actually have more in common than you think. All right, let's list off the things. I can tell you right now. We both care for organs that dilate, obviously, the cervix and the iris. Let's see. We have we both gynecologists and ophthalmologists care deeply for the fundus. We both have specialties that make people outside of our specialty extremely uncomfortable. And the last thing that I could come up with is we are both fond of speculums. We use speculums very routinely to do our jobs and to do it well and to examine things. And it's something we have now. Our speculums look very, very different. It could not be more different, but they are speculums nonetheless. So there you have it. I probably can't say that many name that many things that overlap between ophthalmology and I don't know, cardiology. Maybe there's even less there, or nephrology or gastroenterology. The thing is with eyes though, you can always find something. There is every specialty, and this would be a good series to do. There is 1 degree of separation between ophthalmology and every specialty. I promise you everything. I could find a connection. Even orthopedic surgery, I can find a connection. Did you know that if you have a long bone fracture, some of the fat from inside the bone can travel and get into the eye and cause what's called puerperal retinopathy, where you have diffuse cotton wool spots, basically occlusion of tiny little capillaries? That can happen. There's an ortho connection right there. There are no bones in the eye, but bone things can affect the eyes. That's for sure. So anyway, it was a wonderful experience. It was a great audience too. I always know when there's a lot of med students and residents in the audience, we're going to have a great time. And we did. And it was in Puerto Rico. It's not hard to have fun in Puerto Rico. The weather was amazing. I got a little sunburned, but got to get out of rainy Portland, Oregon. And the whole family came, and the food, incredible. I tell you what, I've been to 2 places this year in 2026 that have some of the best food I've ever had in my life. Puerto Rico, San Juan, absolutely. All the Caribbean. I love Caribbean food. Huge fan. All the things. Mofongo mofongo. Is it is mofongo, right? I think that's how you pronounce it. All the plantain dishes. They had the pork was amazing in San Juan. I was not expecting that. Uh, it, oh, fantastic! But I think what's even better is the food in New Orleans. I went to New Orleans for the first time in about 25 years. I don't know, some reason I just hadn't been there in a long, long time. Went there as a kid. I was in school. It's a band trip I went on. Went back. I think the secret is just I realize I'm not cooking with enough butter. I think that's it. But fantastic food in New Orleans, like unbelievable food. Like I could not stop thinking about how good the food was. It was incredible. So anyway, great time at the gynecology conference. I guess that was the point. All right. So I got a couple things today. So before we get into our first break, after the break, we're going to have something I love about ophthalmology, something I do not like, something dare I say I hate it. I hate it. A disease, a specific disease that really grinds my gears. I do not like it. So we'll get to that after the break. First, though, there was some news about a story that first showed up, made the rounds on social media back in 2024. And you may have heard about this. This is a Florida doctor. I won't say any like Florida man jokes. Those are common. But a Florida doctor that was accused, and not only accused, but he did it. It like happened. He removed a patient's liver instead of the spleen. Do you guys remember this? I ask you as if you're going to respond to me. In August of 2024, it was a surgery that was supposed to be scheduled as a laparoscopic splenectomy because apparently the patient and the family were told that the spleen was like 5 times the size, or it was basically an enlarged spleen, and maybe there's an aneurysm, like a splenic aneurysm, splenic artery aneurysm, who knows? But there was something wrong with the spleen, needed surgery to remove the spleen, a splenectomy, which is a fairly common surgery, and it was a laparoscopic surgery. And then during the surgery, he removed the liver on the other side of the abdomen, underneath the gallbladder, underneath you got to move things around, the pancreas. It's opposite side. Plopped it down on the OR table, and I'm sure to the shock of everybody in the room, and sent it off to pathology. The pathologist is like a clear, and I think the report, you can find like some statements from the report. It was like a very obvious liver labeled as spleen. Like this was bad in the moment. It shocked everybody, and the patient died. And what an awful thing for that patient, for that patient's family. I feel for them, just terrible. And the news recently, this happened in August 2024, is that a grand jury, I'm not sure why this took so long. I'm always shocked by how slowly the justice system moves. A grand jury indicted that doctor on manslaughter charges. Manslaughter. So as physicians, we're always concerned about like civil lawsuits. Like that's like your typical malpractice. You did something that was outside of the scope. There were damages. Patient was hurt, and you are held accountable. Very common. It happens. Mistakes happen. That doesn't mean there was like intent to harm. Like you made a mistake and it hurt somebody, and you're financially liable for it. So that's like the worst case scenario generally for physicians. We're always kind of that's what guides us a lot with our documentation. We want to make sure that we like talk about everything with the patient, document everything adequately. It's like what we're taught day one is make sure that you write everything down. Because we are a very litigious society here in the US, at least. But this is beyond that. Like, this isn't just you made a mistake. I don't, and again, we don't know. This is all conjecture in terms of like why this happened, how this happened. Because this doctor, I remembered reading about this, then I fell back into the rabbit hole. He'd been practicing for 15 years. You go to his Google reviews, which I just looked at, and obviously everything within the past like year and a half is like talking about this thing, like everybody's saying to stay away. I mean, the guy he hasn't had a practicing, like he hasn't been able to practice because he had 2 cases similar to this, and like right back to back. There was the taking the liver out when it should have been a spleen, and another one where he removed part of a pancreas when he wasn't supposed to. Like major issues. The medical board, suspended his license. He's not practicing, thank goodness, and now might be going to prison. But going down this rabbit hole, this guy, like, how does someone get like this? The last time I remember like being interested in something like this was the neurosurgeon, Dr. Dunch, I think his name was. And that whole podcast, and maybe there's going to be a podcast series on this someday. But this guy was practicing for 15 years, and he had some like good reviews to his name from like years ago, like 4 or 5 years ago. And so, but this does make you wonder, like, what was his training like? With Dr. Death, the neurosurgeon, one of the biggest red flags was he was just kind of pushed through training. His numbers were not adequate. He wasn't known to be a good surgeon. It was almost like his residency program just wanted to kind of get him out of their hair. Same thing with several hospitals he worked at. Had some bad outcomes. They just wanted him gone. They wanted, like, go to a different hospital. And that just made things worse, right? Just passing this problem doctor around. Maybe that's the case with this Florida laparoscopic abdominal surgeon. I'm not even sure what his actual specialty was. General surgeon, I guess. Who knows? I assume we're going to find out a lot more because now he's indicted on manslaughter charges. And I mean, this is the most egregious thing I've ever heard as a surgeon. I'm an ophthalmologist. Even you put me in the abdomen with a laparoscopic with a camera, even I could identify a spleen versus a liver. It's not subtle. That's what's so alarming about this, which makes me think there's like 3 possible things here. I can't imagine. There's 3 things could have happened. Either he was inebriated, he was under an influence of either alcohol, drugs, something. He was having a mental health issue, early dementia, something else, delusions, psychosis. I don't know. So, yeah, alcohol, drugs, or mental health, or he was just actually really trying to hurt somebody. Like, obviously, I guess that could be the third thing. I don't know. That's what else could it be? It couldn't just be a mistake. That's not a mistake any doctor makes. Even like non-doctors, honestly, with a rudimentary knowledge of abdominal organs. Like, people know that there's a heart in the middle of your chest. People know your intestines are down below. I bet a lot of people who are not in medicine still know, oh, the liver, that's over here on your right side. The spleen's over here on your left side. I mean, come on, man. So this is devastating for the family and obviously the patient who died. And this type of thing that, he needs to be in jail for something like this. For this degree of negligence, like this is because it's not just a mistake; it can't be a mistake, and it is still kind of shocking to like see a doctor in performing his job, being held criminally liable for something that happened. Like, that is so rare. Dr. Death is one of them. This guy's another one. There haven't been that many, for good reason, right? It takes an egregious act for this to happen. So I'll be interested to see what happens with this guy. But the liver, it has two blood supply. I mean, you can understand why this patient bled out on the operating room table, because it's one of those vascular structures we have, the liver. There's two blood supplies. And so catastrophic blood loss, as soon as you take out the liver, I mean, you can't live without a liver. You can live without a spleen. You can live without a lot of other organs, but not the liver. So anyway, recent news there. All right, let's take a break. We'll come back and that's enough talk about the abdomen. It makes me feel uncomfortable to be down that far below the nasal bridge. So let's go back up to eyeballs after this break. Hey, Kristen, you know what my mom's obsessed with?
What?
Cozy Earth.
Oh, yes, she is. We have gotten her hooked.
Oh, she can't go anywhere without her Cozy Earth.
One in every room.
Which is fine, because now they got the robes and the slippers.
Yes, we should get her for Mother's Day. We should get that.
That's right. And the robes, spacious pockets.
Mm-hmm.
It's and you can tie it up, and it's adjustable ties too. So it's like to fit you whenever. And it got the slippers.
Mm-hmm.
So you're walking around the house. You're wrapped up in cozy. You're walking on cozy.
You are just ensconced in coziness.
There's so much coziness going on for Mother's Day.
That's perfect.
Like, what better way to celebrate Mother's Day?
Honestly, that's all I want, is like a day of coziness on Mother's
Sounds
Day.
Awesome. Let this Mother's Day be a reminder that she deserves care too. Discover how Cozy Earth turns everyday routines into moments of softness and ease. Head to CozyEarth.com and use my code KNOCK for an exclusive 20% off. And if you see a post-purchase survey, be sure to mention you heard about Cozy Earth right here on Knock Knock High, because home starts with mom. Hey, Kristen.
Yeah.
Be honest. Do people think about their eyelids?
Honestly, I don't, unless something's wrong.
They should, because eyelids are amazing. They distribute your tears. They protect you from incoming objects. They're really important for overall eye health as well.
And we both know they can also be affected by something very common, Demodex mites.
Oh, yeah. Demodex blepharitis.
That's
when
right.
Demodex mites overgrow and they start causing problems like itchy, red, irritated eyelids with crusties.
Mm-hmm. Collarettes.
Collarettes, you got it. And everyone should know that if your eyelids aren't healthy, your eyes won't be either. That's why it's important to see an eye doctor, to get an eyelid check, which is part of a normal eye exam.
And the good news is there's a prescription eye drop treatment available for Demodex blepharitis.
It's great news. To learn more about eyelid health and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. I remember doing some laparoscopic surgery. I didn't actually do them. I did suture some of the laparoscopic incisions, like the little 1 centimeter incisions that you put one suture in, or you just glue them and they just close up. That's a good med student job right there. I ran the camera once or twice, and I think I remember getting yelled at for not having the camera in the right place. You know, it's just the typical stuff that happens whenever you're a med student. Okay, so ophthalmology. Coming back from vacation from Puerto Rico is always, it's a little challenging. So I had 5 days off. I wasn't working. First day back, everything went great. Very fortunately, uneventful clinic day. I got surgery tomorrow. Now I'm back in the set. Took me 3 or 4 patients. Okay, all right, I'm back in the rhythm now. All right, cleared the cobwebs out. We're back. That's why I don't like going back I try very hard not to go back to work after a vacation where the first thing I'm doing is surgery. In fact, I don't think I've ever done that. I don't want to do that. I need a little bit of, a runway, a little bit of 1 or 2 patients. That's it. I don't want that to be someone I'm doing surgery on. So clinic, I'm good. I'm back in the saddle. And it was only 5 days, so not that big of a deal. If it was a month off, that'd be a little challenging. I remember coming back to operate and practice after graduating residency, because everyone usually takes off a little bit of time between the end of training and your first job. For me, I needed to start making money, and so it was only about 3 weeks. Some people take a month or 2, and even that was kind of challenging is like, oh man, like you're starting a new job. It's been a while. You take enough of time off and it's just like anything, I mean, a lot of it's like riding a bike, right? I could take a month off from doing surgery and I could still do it just fine. But I might just, be a little slower than I usually am. All right. So things I love. Thing I love about ophthalmology. I went with today. I've been doing this last few weeks. One thing I love about my job. One thing I hate about my job. One thing I love, little kids in glasses. I saw one of these little kids today. Oh my God. It's the cutest thing is those big hyperopic spectacles that make their eyes just look massive, like big, big eyes. And so let's talk a little bit about that. Like when does that happen? When do patients get that? So one of the tricky things about most kids when they're not right when they're born, but shortly thereafter, as their head grows, the eyes, they're a little bit smaller than they are when you're an adult. So you're born, your eyes are about 17 or 18 millimeters long. And they grow, and normal for an adult's like 23, 22 and a half, 23 millimeters. I would say is average length. That would give you, a plano eye. When your eyes are smaller than average, you have hyperopia. Hyperopia is when the focal point of your eye is actually behind the eye. Your eye is not strong enough to be able to refract the light exactly on the fovea. The natural point of refraction is the natural point of focus, I should say, is behind the eye. So what do you have to do to fix that? You have to prescribe glasses, basically magnifying glasses, to give the eyes extra power in order to focus the light more. You're helping the eye out by adding refractive power to just drill in on the fovea. So you have plus lenses, hyperopic lenses. It's the opposite with myopia. If you have a big eye, the focal point is in front of the retina. You don't want that. And so what you have to do is you have to take away a little bit of that power by prescribing myopic lenses. So myopic lenses, you're taking away a little bit of power to allow the eye to focus light directly on the fovea. Hyperopic lenses, the eye is not strong enough. You need to add additional power to get that focal point onto the fovea where you need it. In kids, a normal, healthy kid will be a little bit hyperopic. That's kind of what you want to see, because as the eyes grow, you trend toward myopia. The eyes are growing. So as the eyes get bigger, the focal point starts moving closer and closer to the retina. That's why it's really concerning when you have like a 3 or 4-year-old who's already nearsighted. That's unusual. Most kids who are 3 or 4 years old, they're going to be like +2, +1, +2, maybe +3. But if they're like -2, a family history of myopia, then that's a sign that maybe that kid is going to end up highly nearsighted, like a -8, -9, -10. The earlier in glasses for myopia, it just continues typically as you get, and we're working on things that now there's these special glasses that can slow down the rate of myopia. But your average 2, 3, 4-year-old is going to be hyperopic. And there's not even any sign that they have a problem, because they don't. When you're at +2, +3, that's a low level of hyperopia. That does not need to be corrected with glasses, unless the kid starts having eyes that are crossing. That's when you got to start being a little bit concerned. That's when you need to go take your kid out and see the pediatrician, and then you might be referred to an ophthalmologist, pediatric optometrist, because what happens is if you have higher levels of hyperopia, let's say you're like the kid's like a +3.5, +4. Well, that kid is trying so hard to focus light that it's causing the eye to shift inward. So esotropia, where one eye is straight, one eye is moving inward, and it can flip-flop. That's esotropia. That's really common with higher levels of hyperopia. And so what do you do to treat that? Well, you want to decrease the stimulus of that kid has to focus his eyes. And so you give hyperopic glasses. You give farsighted glasses, basically magnifying glasses, that will decrease the effort that kid has to exert. The focusing he has to exert to bring that focal point onto the retina. So that's why kids often will end up in hyperopic glasses, because they have one eye that's going in. Esotropia. And it's great. You put those lenses on, and they're magnifying glasses, right? And so the eyes look huge. They'll look massive. And they're super cute because they've got these big eyes and this little face, and it helps keep the eyes straight. And that's what you want. Because if you don't put that kid in glasses and they have one eye, let's say it's their weaker eye, the one that has a stronger prescription, is constantly moving in, the developing brain is able to just ignore the neurologic input to that eye. And so that kid will not develop normal vision in the eye that's moving inward. They'll just use their good eye. Kids don't care. They can turn out their brains are so plastic that they can just turn off half of their vision part of their brain and just focus on their good eye. They're like, forget about that other eye. It's bad. But that becomes permanent around age 7 or 8 or 9. Once the brain kind of locks in. So you have this very short period of time where you can develop normal vision in the eye that's crossing, that's going in, that's esotropic. But that means you got to recognize it. You got to give the kid glasses, straighten the eyes. And sometimes that's not enough. And you have to actually do surgery to make the eyes straight. And sometimes you have to actually do patching, where you occlude. Those of you who have had patching as a kid, this is the reason. It's because you had one eye that was quote unquote a lazy eye. So you cover the good eye, forcing the kid to use the bad eye. And kids hate it. Does it? But it works. It works. Because what else can they do? They have to use it. And the brain's going to start developing. And you do it like maybe a couple hours a day, or 6 hours a day, or 8 hours a day. So it's not all the time, because then you'll switch you'll switch the laziness to the other eye. If you occlude the good eye, well, then it might become the bad eye, because the kid's like, okay, well, I'll just develop this good eye. The kid's brain is saying, I'll develop the bad eye. And then what was previously the good eye now has become bad. So, but a lot of times you don't have to do the patching. You don't have to do surgery, because for mild cases, you can just prescribe those hyperopic glasses that I love so much. And the eyes are straight and the vision develops normally. And the kids often will grow out of those glasses. Sometimes not, but sometimes they do. As their eyes get bigger and they trend toward myopia, they become less hyperopic and become more closer to myopic. That's something I love about ophthalmology. Here's something I hate. Giant cell arteritis. I am not a fan of this disease. I'm not a fan of how scared we are of it, for good reason, but also how rare it is. It's just this, like, we're terrified of this disease. So I actually was reading up on the history of giant cell arteritis. So first, giant cell arteritis, it's also known as temporal arteritis. It's a vasculitis that affects older adults. In fact, it's almost unheard of under 50 years old. It really doesn't even cross our mind under the age of 50. Like, that's reportable. You could publish a case of it if it occurs in someone under the age of 50. And it does get a little bit like the median age is about 75. So I really start thinking about it once someone gets into their 60s. All right. Even like a 55-year-old, extremely unlikely. Not unheard of, extremely unlikely. So it affects older adults. and it causes granulomatous inflammation of medium to large vessels. That includes vessels in the brain, but also in the heart. All right, it can affect multiple different organs because it's a systemic vasculitis. But the history is interesting. I didn't know this. Let me tell you something I just learned right before I started recording this episode. References to giant cell arteritis can be found dating all the way back to the 10th century in Baghdad. The earliest observation was recorded by an ophthalmologist, and I butcher this name, but I'm gonna try anyway. Ali ibn Isa al-Kahal. Sorry, I'm so sorry. Who discussed a potential relationship between inflamed arteries and visual signs and symptoms. This is incredible. This is 10th century. He noted that these diseased conditions may terminate in loss of sight, and he suggested that excising the temporal arteries in order to treat patients and save their vision might be helpful. Now, that ended up not being correct. You cannot remove any artery to treat this disease. It's a systemic inflammatory disorder, right? You got to decrease the inflammation. But we do remove the temporal arteries. And so the part of the reason probably that this ophthalmologist in Baghdad made this connection is because with giant cell arteritis, for like rip-roaring, very obvious giant cell arteritis, you're going to have a big, dilated, tortuous, painful, throbbing temporal artery. You're going to see it right there in the temple. It's a fairly superficial, medium-sized artery. So when it gets big and angry and inflamed, it's going to poke out. And in those patients, he probably saw that some of them were losing their vision on that same side. They were going blind suddenly. And that's something that we see. Giant cell arteritis can cause these symptoms. The most common symptom, so the classic symptoms of giant cell arteritis is temporal headache. So right over that artery, you get pain. Scalp tenderness, kind of hurts to brush your hair back. You can get jaw claudication because you have these arteries that supply the muscles in your jaw. So you can have what's called jaw claudication, or you just kind of get really tired the longer you eat, to where you have to stop eating sometimes. And then the most devastating thing is episodes of vision loss that we call amaurosis fugax. So amaurosis is when you have, this is a very important distinction of what exactly amaurosis is, because people call amaurosis a lot of different things. This is amaurosis. This is exactly what it is. It's gradual loss of vision over the course of, I'd say, 2 to 3 minutes, to where the vision is mostly grayed or blacked out. Like, we're talking significant loss of vision, sometimes just part of the vision, but it's very clearly a blackout or gray out of vision that lasts maybe 5 minutes at most, and then gradually returns and completely resolves. That is your classic description of amaurosis fugax. It doesn't last 30 minutes, doesn't last an hour, doesn't last 5 seconds, or even 30 seconds. All right? It is a very specific time period that amaurosis fugax lasts. It is on the order of minutes, not hours, not seconds. And it's very concerning, especially in this age group. So let's say a patient came in and was having these episodes. I would immediately send for ESR, CRP. I might even, if it's really concerning, might send the patient over to the emergency department to get this done. ESR, CRP, platelet count, that can, if there's high platelets, that can be a sign of giant cell arteritis. And then if the symptoms are concerning enough and the labs are high enough, if the ESR is elevated, the CRP is elevated, then right then and there, I'm starting steroids. You start it based on a clinical exam, clinical picture. I'm starting high dose steroids, usually about 60 milligrams per day. Now you might be thinking, well, how do you know exactly that that's what you're treating? Well, I don't 100%, but my probability, but the likelihood that it's giant cell arteritis in someone who has temporal pain, they have episodes of amaurosis, they're 75 years old, they have a high ESR CRP, like that is giant cell arteritis until proven otherwise. And I'm starting steroids right away because you can completely lose vision in both eyes from this. You can die from this disease. That's why we're so nervous about it. That's why it scares ophthalmologists so much. If we have strong enough suspicion, we're going to start the steroids. But here's the thing. If you start steroids because you're presumably to treat giant cell arteritis, then you have to set that patient up for a temporal artery biopsy. You have to get a tissue diagnosis, because ultimately that's what you need. So, and that needs to be done within about 10 days. Really as soon as you can, but certainly within a week would be like a good idea. Got to be within 10 days. Otherwise, the treatment may mask the inflammation that you see. So you get a biopsy on the affected side. If that's normal and you still have a strong suspicion, you get one on the other side as well. If everything is, if there's no giant cell arteritis present in the tissue, then you can start tapering off the steroid as long as the patient's not actively having symptoms. But the point is, we just got to be very careful. Even though this is a rare disease, estimates are about 2 cases per 100,000 per year in the 6th decade of life. But that goes up to 44 cases per 100,000 per year in the 9th decade. So as you get older, it gets much, much more common. African and Asian and Arab populations have the lowest reported rates. This is much more common in Northern European descent. Other risk factors, smoking is a risk factor for this, and another reason not to smoke. So it's very uncommon, but it's always on our radar. We're always thinking about it. It's not the only cause of amaurosis, obviously. It could be, you could have an occlusion. Basically, what amaurosis indicates is just a loss of blood flow. That can be for a variety of different reasons. It can certainly be from a giant cell arteritis. It could be other forms of vasculitis. It could be an occlusion of your carotid artery. You could have a clot that's occluding the carotid artery, decreasing the flow of blood to the central retinal artery, the ophthalmic artery, causing a blackout of your vision that's temporary, and then it comes back. So all these things you got to think about. What could be the cause of a decrease in blood flow to the eye, because that's what amaurosis is. Like most of the time. You can get similar symptoms in like atypical migraine and things, but you think about that after you've ruled out all these really like possibly harmful things. And then these patients often have to be on steroids for months. Sometimes it takes years before you finally get the taper down, and you got to be careful, because if their symptoms start back up, well, you got to go back up on the steroids. I've seen patients that you go down by like 1 milligram every 6 months. Like sometimes it's like that long of a taper. Fortunately, it's rare, but it can be devastating. So we got to take it very seriously and keep it on your differential. And that's why I don't like it. I hate that disease. I hate it. It's so hard for patients, because high dose steroids, you guys, it is not a trivial treatment. Those of us who have used steroids and treat patients with steroids know, like, it causes GI issues. It can cause all kinds of mental health problems. You feel good, and initially you're like, you get a buzz from steroid. You're all of a sudden very active, and you got tons of energy, but then all the other effects start taking over, and it changes the appearance of your body when you've been on it for months and years. And you can have osteoporosis and just all these harmful effects. And so it's not a benign thing. It can wreak havoc on your blood sugar control as well. So it's always tough for patients who have diabetes who have to be on high dose steroids. So it can cause diabetes. And so it's like all kinds of things. So it's not trivial. It's a challenging step to take, but sometimes you have to do it. That's it for Knock Knock Eye, folks. Let me know do you have anything that you really love and really hate about your field? I would love to hear about it. And talk about it. Let's hear it. Let's learn from each other. Thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Brooke. Editor and engineers, Asia Portiz. Our music is by Omer Benzvi. I am Dr. Galactifleck, also known as Will Flannery. That's it. We'll see you next time, everyone.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.